CHÉOS exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
Thanks for attending Work in Progress Rounds. My name is Frank Schiermeyer. I'm an emergency physician and the Director of Research for PhD Emergency Medicine. And today we have a very interesting talk. I'd like to start off by acknowledging the fact that we're gathering on the unceded territory of the Coast Salish peoples, including the territory of the Musqueam, Squamish, and Tsleil-Waututh nations. So thank you. So this is Dr. Andrew Kestler. Have you done one of these before, Dr. Kestler? You have not done? Okay, well, join the club. So he's an emergency physician at St. Paul's and Vancouver General in Vancouver, and a clinical associate professor of emergency medicine at the University of British Columbia. Now, normally I look up when I talk, but there's so much master's degrees and other stuff here I gotta read off of here. He's a CHÉOS scientist and affiliated with the BC Centre on Substance Use, as well as the Canadian Research Initiative on Substance Misuse. He does additional training in healthcare administration, public health, and tropical medicine. He lived and worked in Botswana. It's very tough to work in Botswana if you're not living there, I imagine. So from 2008 to 2012, where he oversaw the launch of a new emergency medicine residency program. His current research and public health efforts focus on emergency department interventions for patients with substance use disorders. His prior projects include an evaluation of a novel emergency department take-home naloxone distribution kit and the development of a take-home naloxone distribution app. He currently serves on hospital, regional, and provincial committees to improve emergency department-based responses to the opioid overdose epidemic. His ongoing work focuses on implementing opioid agonist therapy, specifically buprenorphine naloxone, or Suboxone, in the emergency department. Through a CHR grant through his foundation, he's completed a national survey of emergency physicians on attitudes towards receiving opioid agonist therapy in the emergency department, something that traditionally has not been done by emergency physicians. His latest project, also supported by VCHRI, entails offering emergency department patients buprenorphine naloxone to-go packs for home initiation, and then using local resources to follow patients up for up to 1 year. So thank you.
Thank you, Frank, for the introduction. Thank you to those of you for finding this room as we were booted from one room and moved to here. So as Frank mentioned, I am an emergency physician, mostly at St. Paul's, also at Mount St. Joseph, and at VGH. So the main thing I'm hoping to talk to or want to share with you today is some of our work in opioid agonist or OAT implementation in the emergency department. Let's see if I can get this to work. I cannot. Okay. Interesting. Oh, here we go. All right. I don't really need to go into this in full depth. I'm lucky enough to have some grant support from both regional, national, and some local foundations and support. And all the projects I'm doing are involve large teams, and I'm grateful for a lot of people in different professions, pharmacists, nurses, addiction specialists, so lots of different fields working on both sort of the research side and the QI, or quality improvement side of this initiative. And you will see as I'm talking that these two threads interweave each other frequently, and really this is about rolling out a project or rolling out a program and making sure that we can show that it works. So I want to give you some background on opioid agonist therapy. It's a little bit of a convoluted course of how we ended up talking about opioid agonist therapy in the emergency department. It certainly hasn't been in emergency physicians' traditional wheelhouse. All the more reason to do a survey of this intervention to see what emergency physicians actually think about it, and I'll be talking about that. And then I'll get to our sort of current larger project in the emergency involving buprenorphine to-go packs and intensive overdose outreach team follow-up. So this is sort of the slide that you can't avoid showing, or this is just a reminder of where we are in the opioid overdose epidemic in BC. maybe a little bit of good news that it has leveled off in the next year. In terms of the mortality rate per 100,000, we are still in the lead nationally, and typically in terms of the postal codes or the geographic areas in central Vancouver, we have the highest mortality rates of pretty much any zone in BC. So why are we talking about this for the emergency department? I mean, this is a large public health problem that affects various different aspects of the healthcare system. So why the emergency department? Well, one of the reasons is that we know anecdotally and also from the data that lots of people with opioid use disorder actually come to see us in the emergency department. So we are seeing these patients. Some patients have limited contact with the healthcare system outside of the emergency department. So there's an opportunity there. And also some people cycle through relatively frequently, so that some people, about a third of people who present to the emergency department for related to something with opioid use disorder are actually going to pop back through within the next month or so. And we know that the people who pop through the emergency department are at high risk of short-term death. And these rates of mortality are comparable or higher than lots of the other coronary artery disease, strokes, other significant conditions that we see and that we're used to attending to in emergency departments. These are certainly comparable one-year mortality rates, if not higher. So this is data from St. Paul's that a team of us looked at with Andy Jiang in the lead, and looking at over 2,000 overdose patients who were seen at St. Paul's over a period of about 4 years. 6% of them were dead in 1 year. And if you looked at the people who came in the tail end of that cohort in 2017, when fentanyl prevalence was increased in Vancouver, the mortality was even higher at 8% in 1 year. If you look at it the other way around, if you look at all the people who did die, these people did pass through our emergency department. So these were about 400 people who died of overdoses in Vancouver Coastal Health, and 70% of them had been to an emergency department within the last year. And I think for those of you who are not intimately familiar with this area of opioid agonist therapy, this is a very effective intervention for opioid use disorder in terms of survival. That is, if you can get people onto it, which is a major challenge into itself. But this is a meta-analysis from Sordo in 2017. It shows you that the mortality rates for either methadone or buprenorphine naloxone, which are the two mainstays of opioid agonist therapy in Canada and around the world, mortality is cut in half. And this is true not just in this meta-analysis, this is true in BC data also. This is from Bodanosik, and you will see that a healthy person in the 30 to 34 age group in BC, probably 1 death per 1,000 person years. If that person has opioid use disorder and has never been on opioid agonist therapy, that mortality is about 20 times higher. And if you get that person onto opioid agonist therapy, then that mortality is still outrageously high compared to a young, sort of middle of the road 30 to 34-year-old, but it's been halved compared to when they're not on opioid agonist therapy. And so that brings us to why would we do opioid agonist therapy in the ED? Well, there's evidence now that it works. The landmark trial came out of Yale. D'Onofrio and colleagues published this in 2015, which showed that if you start people on buprenorphine naloxone in the ED, the rates of follow-up in addiction care, engagement addiction care, are twice as high as if you just sort of refer somebody to an addiction clinic. So I think it was approximately 78% compared to around 37%. So a doubling of follow-up. And this isn't just possible in academic centers with research funding. This is possible in community EDs, and this was a paper that came out just this year from Hu and colleagues, and I believe that's been cut off, unfortunately, but from a health system in Ontario, and they were also able to demonstrate successful emergency department buprenorphine naloxone starts and fairly high rates of continued engagement in addiction care. So how are we doing in BC? In BC, this is also from Bodan Nozick, we can see that there's a big drop-off in the people who are diagnosed with opioid use disorder and the people who actually end up on opioid agonist therapy. Approximately 31%. So there's room to improve. And the other area there's perhaps room to improve is this sort of gray area that represents undiagnosed, presumed but undiagnosed opioid use disorder. So there's something we can potentially do in the emergency department. One is to do a better job of identifying people, detecting people who may be in that left gray zone who are not yet diagnosed. And we also have an opportunity, once we identify those people, to get them onto opioid agonist therapy. If you just focus on opioid overdoses, you are going to miss many patients, at least in the emergency department. So this was data from some screening for another study that we did in 2015, which showed if you look at a sample of people with opioid use disorder who come into the emergency department, very few of those, so about 20% only, are presenting with opioid overdoses. And then the other, I mean, there are a few things which you might pick up as actually being opioid-related, some withdrawal, some requests for detox, some soft tissue infections that might be consistent with injection drug use, but still the vast majority, so over 50%, had other complaints, chest pain, belly pain, other things that you would not think are necessarily opioid-related. And I guess the other challenge to keep in mind, also specifically if you focus on overdoses as a way of identifying people with opioid use disorder, is that not all people who overdose actually have opioid use disorder. So this is, again, a review of VCH overdose deaths, and showing that maybe only about 40% had relatively pure opioid use disorder. Other people, maybe about 20%, were just occasional users of opioids, and a very good chunk, so over 40%, had mixed disorders with lots of different kinds of substance use. So all these factors together, looking at the data from around North America and knowing or starting to understand some of these things I've just described, made us want to have buprenorphine and naloxone in our ED. We felt we definitely are seeing people with opioid use disorder. That's well known, and now there's some interventions that we can offer people. So we launched this in June. And I'm not going to go into this specific intervention in great detail, but the bottom line is it didn't work that well. And some of it has to do with patient factors. So in our patient population, many people did not come in sufficient withdrawal to start buprenorphine and naloxone. And for those of you who are not very familiar with buprenorphine and naloxone, for it to work or for it to start it, you have to be in opioid withdrawal. The danger is if you're not in opioid withdrawal, because it's a partial agonist-antagonist, it can actually force you into withdrawal, into what's called precipitated withdrawal, and that's something that we don't want to do, because many people will say if somebody has been in precipitated withdrawal, they will never touch buprenorphine again. And that's probably not entirely true, but it certainly is true for a lot of people. Again, so these are just some of the, anecdotally anyway, some of the reasons we identified why it wasn't working so well. Also, the emergency department is not a place that a lot of our patients want to hang out. It's not a warm, fuzzy place for them. And again, there are also some provider factors. A lot, I think, of emergency physicians feel we may not have enough time. Maybe there's this fear of precipitated withdrawal. Maybe there are some biases against people who have opioid use disorder or other substance use disorders. Again, these were presumed. We hadn't sort of studied this in depth, but just in terms of anecdotal conversations of why this program perhaps wasn't working so well. And this is despite being really a center of excellence for addiction care, in that we have addiction teams and we have all these people and resources at our disposal. But often, even if we call somebody up to say, hey, can you please see Mr. Smith in the emergency department, by the time that they come down, that patient is gone. So we were having difficulties with this project. So we went back to this paper from D'Onofrio and colleagues, and if you read the fine print, you see that actually over half the people in the buprenorphine group actually received to-go dosing. They were not in acute withdrawal. They were not candidates for immediate starts. And so they got to-go dosing, and in this patient population, or in their study group, they found that that to-go dosing in terms of retention and follow-up care was just as good as the starts that happened in the emergency department. And I think the other part to consider is, so it's not only about to-go dosing is a good idea. The other part that we see is key from some of the Yale data also, this is sort of a follow-up study of the same cohort of patients they initially enrolled. So they saw that their retention in care really dropped after a couple months, and that is around the same time that they cut off their more intensive follow-up. So it seems, and it's as intuitive, if you have a lot of outreach, a lot of intensive follow-up, people are more likely to be retained in care. So we're very fortunate, and again, I want to try to set the landscape for Vancouver and what's going on here. We have an overdose outreach team, and these people, this team is amazing. They have a very high success rate, about 90% of contacting our emergency department patients with opiate use disorder within 3 days after their emergency department visit. And again, the one, I guess, that's a strength. One possible weakness is they don't follow people for long periods of time. It's one episode of care, maybe a few repeated visits over a couple weeks, but really with the goal of just getting somebody engaged into care, but it's not longitudinal follow-up. And also working with our IT, we've been able to find other ways to facilitate the referral to the overdose outreach team so that as many of our patients with opioid use disorder as possible are followed up with the overdose outreach team. So even with all these resources in place, when we sort of had our ED Suboxone starts, we still felt like we were missing the boat. We have sort of by our estimates about 1,000 patients with opioid use disorder are rolling through the ED every day. Not every day, sorry, every month. And that maybe about 10% of those are referred to the addiction clinic. Maybe about a quarter of that amount actually show up at the addiction clinic. And then maybe just a small handful, so perhaps 1 to 2% of that initial 1,000 end up on opioid agonist therapy. And that's new opioid agonist therapy. It's certainly within that 1,000, there are people who are already on opioid agonist therapy. So that's why, putting all these things together, that's why we wanted to initiate a to-go program for buprenorphine naloxone in our ED. We launched this in December 2018, and it was meant to be as low barrier as possible for the patient, so no need for an extra trip to the pharmacy, no need for a very long emergency department stay, and low barrier for the provider. So no need to write a prescription, no need for a long period of observation. And then we dovetailed this to take advantage of the overdose outreach team, or OOT, and all the patients who received BTG were automatically referred to to OOT. So this is what the pre-pack looks like. So they're 3-day supply of the medication with 3 different envelopes for day 1, day 2, day 3. The formulation has changed slightly since these initial pictures. We're now using some individual sort of vacuum packed, which are supposed to have a little bit better shelf life than what we had right here. But anyway, the basic idea is still the same. And the key piece, of course, is that the patient knows how to take it. And so there's a handout that's gone through several rounds of testing and basically walking people what to do and not to. The main thing really is to wait until they're in withdrawal to start, and then there are instructions on how to take it. Then there's sort of some follow-up dosing on day 2 and day 3, and then the important part is that follow-up in a place where people can get ongoing care. So really the emergency department is just a bridge. We are not the end-all be-all. We are not the place to manage this opioid agonist therapy. We are the people, I think, who are in a good position to start the treatment and then get them to the next place for care. I want to give you a little information on how things have panned out so far, and we've been in these sort of last 9 months or so, we've been in a bit of a preliminary rollout phase where the only people or the only role that is dispensing this medication are addiction assessment nurses, and they're only around during the daytime. So essentially we've been working on this project with only 8 to 10 hours of coverage a day, not 24/7. So we're now entering phase 2 where we're looking to go 24/7. We have nurse training in progress through a Learning Hub course, and then we hope within the next couple weeks, once a critical mass, perhaps 20 to 25% of our emergency department nurses have been trained, then we will sort of go 24/7 for this program. And this is some preliminary data from our phase 1. During the first 9 months of the program, we dispensed approximately 6 kits per month. And at 1 month follow-up, approximately 30%, almost a third, were on opioid agonist therapy. And we feel relatively good about this because we are targeting, remember, people who are currently not on opioid agonist therapy and who in some ways may be the most difficult to reach or difficult to treat. Still, though, to go back for a second, we're not super happy with that. We feel that 6 kits a month, given all the people with opioid use disorder we have coming through the ED, that is not a lot. We feel like we should at least be able to double that, perhaps more. So as part of sort of both our research and QI agendas, we want to sort of look at the different factors. How can we better use that ED visit as an opportunity to get somebody plugged in and started on OAT, or at least get plugged in with ongoing care? And so the first area I'm going to talk about are the MD factors. So we did a local survey, which then blossomed into a national survey to get a better feeling, at least of what are the provider factors going into sort of this equation of what's going on up there. So this is sort of just a quick run through of our national survey, which we just completed. I don't have any data to share with you specifically overall, but I do have sort of the participation rates. So we had 23 ED groups across 6 provinces, and we were able, through strategies which I'll talk about in just a second, achieve 85% participation and had over 600 responses around the country. So how did we get those high participation rates? We found a designated site champion at every place, and not just a site lead who was willing to do the survey, but somebody who actually cared about opioid use disorder and taking care of addictions, because we wanted to be the results of the survey, at least on a local level, to be actionable for that person. And then we had funding for an incentive plan of $10 per participant. That could be an individual gift certificate, or they could be certain group incentives such as a raffle or a group lunch. We had the strategy of giving a paper survey at pre-planned high attendance regular group meetings. So the quarterly meeting, however the group would usually meet, that's where we would do the survey. And then there was an online mop-up strategy with an online survey for the stragglers with a goal of achieving 75% participation. So I have just a little data to present or share with you from our group at St. Paul's. So 100% of our physicians took the survey back in December of last year, so it's been about a year. At that time, about half the physicians were versed enough with buprenorphine naloxone to order it about once a month. In terms of the to-go dosing, the buprenorphine for home induction, 70% of people had never done this. So that was the practice pattern at that time. In terms of the willingness, overall, people were quite willing to engage in opiate harm reduction interventions. And the highest one on the left is giving a take-home naloxone kit or Narcan kit. And you can see that that's something that's been around for a few years in BC. People are quite comfortable with, and they felt 100% willing to do this, and it was lower when you got down to buprenorphine naloxone starts, and especially around this idea of to-go dosing or getting ready somebody for a home induction, where about almost a quarter of people weren't so sure about that. The barriers that were identified, again, the ones that we hypothesized would be there in the first place, that's also what came out in the survey. So lack of time in the clinical encounter, lack of good spaces to have the kind of discussion you need to have with a patient about starting buprenorphine naloxone, and still a feeling of lack of training that, okay, maybe we don't understand buprenorphine naloxone well enough to feel comfortable with this. So these are just some quick lessons that we've learned so far. I think the willingness overall is pretty high, at least in our physicians, and this mirrors in very preliminary analysis that we've done of BC data and national data. This same sort of thing is happening provincially and nationally. People are pretty comfortable with the idea of starting buprenorphine naloxone, less comfortable about starting it for prescribing it for home induction. And then we've identified some barriers that we think are possible to work on in terms of, for example, coming up with time-saving measures, and also have some more training specifically around home starts. So that was just a quick look at the physician side, and so now just sort of moving into other areas or other parts of the picture. This brings us to our buprenorphine to go and intensive outreach study. So we wanted to look at patient factors. So here we're doing some patient surveys and interviews. We wanted to see how we could take maximal advantage of the overdose outreach team by having more intensive follow-up by the overdose outreach team, and we also wanted to have tracking of outcomes through regional and provincial databases. So this sort of was the underpinning of this study, and our patient populations were people with opioid use disorder in the emergency department who were not yet on OAT. The intervention was offering this buprenorphine to go pack for a home start, and also enrolling them in this one-year intensive follow-up program. And the comparison, there's no comparison group per se, it's an internal comparison where the patients who are enrolled looking at their experience with OAT and healthcare utilization in the year prior to enrollment. And the outcome again are that OAT initiation, retention, post-enrollment. People we excluded, people who lived outside of the catchment area because our overdose outreach team can't follow them up there. Minors were excluded. People who were in acute withdrawal because those people are candidates for an immediate start of buprenorphine naloxone. People who might be thought of having complicated opioid use disorder, perhaps pregnant or having severe comorbidity. Not that they aren't candidates entirely for buprenorphine naloxone, but that we would want some addiction input on their care. And then in terms of the definition of who currently was on OAT, who would not be eligible, for people who are on it within the last 5 days. So that's who we're not counting. And so what's the process of our enrollment? So we have research assistants who are in the ED and use some predefined screening criteria to identify likely people with opioid use disorder. Then they approach these candidates and they inform them of the ability of this BTG program and also about this intensive follow-up study, which includes an intake survey, which is compensated as a recognition of the person's time. We use a screening tool called RODS to confirm opioid use disorder. And just to clarify, the eligibility is not contingent on the person accepting this buprenorphine to go or BTG. It's really the act or the service we want to make sure is delivered is that they've been offered it, and then they're plugged in with the intensive follow-up. They do not have to accept the BTG to be part of the study. And then we have this one-year period of follow-up with the overdose outreach team. We have a research team member who's embedded with OOT. They will have at least 4 follow-up encounters during the course of the year. During 4 of those, there will be a follow-up questionnaire. And some of the items we are targeting in this follow-up questionnaire, just like an intake questionnaire, are current drug use, OAT use, and overall well-being. And then there's also an invitation within a smaller subset for an in-depth qualitative interview. And then the other part of the follow-up is using existing databases. So we'll be using regional databases, looking at ED visits, hospitalization, community encounters through Paris, for example. And then there's the connection and linkages to provincial databases through PopData BC, where we can get some additional information, including their PharmaNet records. And so I think I want to share with you some of the information from our screening so far. And in many of the work I've been involved with, I feel that sort of the screening process is almost as interesting, or you learn as much from it as you do in the actual, the full study itself. But we screened over 160 people in the first 2.5 weeks of the study. And I guess the good news is that over 60% of people were already on OAT. So that's great for our patient population, less good for our study, but that's certainly a good thing. So this is probably double the rate than in BC as a whole. I think I presented some data earlier today where we showed about maybe 30% of people with opioid use disorder are currently on OAT. Here we find about 63%. The two other sort of largest areas for exclusions are people being too sedated to enroll or to give informed consent, and also leaving before they're approached. And those two groups do overlap because what many of us have seen clinically and bears out with the screening process is that many people are sedated, and then within a span of 5 minutes they're awake and they walk out the door. And that challenge of enrolling somebody in a study like this is also the same challenge we face clinically every day in terms of offering interventions to people. That window of opportunity is so small. And again, this is not from our study, but this is just showing you data from our emergency department that we regularly have 10% of our post-overdose patients who leave without being seen. That's it can easily be up to 20% in some weeks, depending on the patient volume. And this is not even counting the people who leave before the clinical encounter is complete, which would be another several percentage points above that. So far in the first month and a little bit, we've enrolled 30 patients in the study. About fewer than half the people actually accept the buprenorphine to go. All the others, to be in the study in a way, they are consenting to that intensive follow-up over a period of 1 year. We are adding VGH as a study site starting in January. And our enrollment target is between 160 and 200, we hope by May of 2020. And so as I sort of get to wrapping up here and opening up for questions, I want to put this in context. So this is just one sort of study and QI process among many. We have our own QI process at St. Paul's around ED OAT initiation. There are initiatives afoot at the Vancouver coastal regional level to expand BTG to other emergency departments. VGH has started, Richmond and some other places are about to start, and I know Lionsgate is thinking about it also at some point. And then we're looking at also provincial strategies to make ED OAT more commonplace around the province. And just to sort of share some of those specific QI efforts with you, we have a QI team at St. Paul's, and we're looking at all these efforts, or all these factors, working on nurse training and nurse opinion to work on some of the nurse factors, looking at the patient factors, and looking at improving the ED environment, which in many ways is not patient-friendly, at least for some of our patients with substance use disorder, and also, of course, working on better coordination with the overdose outreach team. So those are some of our QI efforts at St. Paul's. I'm part of a province-wide QI effort, which is called the ED Loud or loud in the ED collaborative. And again, something that we hope will provide some basic tools for emergency departments around the province to be able to start or improve their own ED OAT programs, and again, taking into account regional and local differences, urban versus rural, and the type of resources that people have at their disposal. So to close, I think we're really in a unique position, or I feel fortunate to work at St. Paul's, which is a bit of an opiate use disorder hotspot in the province. And as I mentioned earlier, the province is a bit of a hotspot nationally. So it really gives us an opportunity to be a proving ground. We can answer some research questions, we can improve care, and then we can play a lead role in scaling up things regionally, provincially, nationally, and beyond. And I guess the other certainly key point, which is always reinforced to me, is just how important it is to have a multidisciplinary approach, and that certainly includes patient input, which we've been able to obtain through peer advisors and also directly through our questionnaires involving patients. So with that, I'll open it up to questions.